Hello, this is Joanne Smith from the AHCWP. The following is a recording of a session with the AHCWP members about workforce planning challenges led by Colin Lewry. It's a podcast and also you can find it on YouTube. Colin talks about workforce planning challenges with the members and also introduces some cards which summarise the challenges and some possible solutions, which can be seen on the YouTube version of this recording. Okay, it starts with Colin introducing the topic.
What we normally do is we teach workforce planning, which is now being done through the association. We teach a half-day course called An Introduction to Workforce Planning, and one of the first sessions we do is about an hour on barriers to workforce planning, and we also look at solutions as well. So we're not just looking at barriers. Why do we look at that? Well, I have been told in no uncertain terms to get knotted when trying to do work in a GP practice once because they weren't able to do it for various reasons. Quite often, there are many, many barriers to workforce planning. We've talked before, and we have written an article called Why Workforce Planning is Impossible, and sometimes it feels that way. So part of this session really is to make you understand that you're not alone with a lot of these issues, and we've just got to find our way through them, really. The second part of it is to think about how we might negotiate through some of these issues. So what I want to do is really try and get the issues out on the table first, and then talk about a couple of them about how we might address them. And while I'm doing it, I'm going to introduce you to the workforce planning barrier cards that we use in the course, and will be available through emailing Joanne, and we'll get them up on the website when we next do an update on the resources. These cards are used as part of our Train the Trainer, so that if you want to train other people in these, then you can use the cards to help train people. But what I'd like to start is with getting your thoughts on do you think are the main challenges? What are the main things that get in the way of workforce planning in your organisation generally? Any thoughts at all? What are the things that get in the way? What are the barriers in your view? David?
Finance.
What do you mean by finance? There's a couple around there, but yes, absolutely.
Just in general, with obviously there are constraints around budgets and what we're being funded for. Also, time as well. I think time's a bit of a barrier in terms of, especially if you're looking at clinical managers doing some workforce planning as well. Their time is quite precious in terms of doing the clinical side. So getting them to workforce plans quite a challenge.
I think if this was Family Fortunes, you'd have won. You'd have got the top three answers and probably won a barbecue set or something at this point. Because those are my top. I've given you three there because you talked about finance and just said finance, and that is one. So finance gets in the way of things. We'll talk a little bit more about that in a second. And then we talked about money. We haven't got enough money at the minute. Everyone's under pressure, so of course that gets in the way. And then you talked about not enough time. So yeah, absolutely not enough time to do workforce planning in general. So that's three knocked off straight away. So let's come in, Lisa, first of all. Thank you.
I think Gino and I have just had this discussion that the amount of transformation, particularly digital transformation that's going on at the moment, is making it quite difficult for us as part of the new hospital programme to know where's that all going to land and what that's going to mean for our workforce.
Absolutely, 100%. So you've actually got number 4 there. So you're doing really well. The sheer scale of what we've got to do here. Absolutely. And you've got a new hospital coming as well. And the sheer size of the digital scale, the huge amount of stuff that we've got to do. There's loads of new workforce models out there. The sheer scale of it is quite scary. Sakura.
Yeah, it's one of the challenges is around the limited timeframes around the funding. So you got short-term funding, so the cycles are quite limited, and therefore obviously we've got a massive challenge around long-term planning because you can't plan with very limited funding cycles.
Right, absolutely, 100%. That's not on my list because you could probably stick that under finance to an extent, but you're absolutely right. That short-term funding has really got in the way. I give you some examples. Great amount of money made available for staff to do AHP redesign in their organisations, an AHP workforce lead. Then that money disappeared. suddenly there's no work going on at AHPs. You spend a load of time getting those people up to speed. They've done a load of work and then nobody's doing it. Other things that might happen from a short-term funding point of view is that people are in short-term roles and they don't feel able to progress things. They're also worried about their positions, etc. So there's quite a lot wrapped up in that. M.
Somebody's put in the chat, I was going to say workforce supply, so I'm going to come up with another one. So fear of change. So we've always done it this way. Why do we need to change it?
Absolutely. So that's an interesting one. You're exactly right. That is a barrier to it. It's such a key barrier, that fear of change. Yeah, absolutely. It's because of the change. You've got to get everybody through this journey when you're redesigning and changing things. That's a major one. So thank you for that. And then workforce supply. Absolutely. Where are we going to get the workforce from? Some of these things they're part of what makes part of our job, I suppose, aren't they? That dealing with change and workforce supply. Nikki.
The key one for me at the moment is we are in very uncertain times. So the lack of buy-in due to the ongoing uncertainty within the NHS. We've got changing leadership positions as some of us are moving to acute collaborative hospitals. We've got changes in leadership within ICBs, etc. So it's that constant ongoing change and securing buy-in when people's own futures are slightly uncertain.
Yeah, absolutely. Now that is a joy of the health and care sector at the moment. Even when people are around, quite a lot of the time, people don't really care about workforce planning. And what I mean by that is that everyone gets shouted at about money, so they do stuff about it. People worry about quality of provision quite often. They don't want people to die or be injured or whatever by what's going on. But a lot of the time, people just do not care about workforce planning at all until it's often too late. But yeah, that lack of buy-in to the problem as a whole, especially at the moment, given the chaos and mayhem across the systems, absolutely right.
We've got a few in the chat, Colin.
Cool. Go on.
So I'll read them out in order. First one, the role of technology on the ways of working in the medium term to fully understand future needs. Correct me if I'm wrong, but I guess that's uncertainty about what technology is doing now and what it's going to do in the future.
A lot of that fits into the sheer scale, but also this whole idea that we really need to think about some bold change if we're going to make the changes that we need to make, especially given the financial pressures, etc. So if we don't understand the impact of AI, robotic process automation and stuff like that, as well as the plethora of a huge amount of stuff that's going on, we need some bold change. And yet it's difficult because we've got no money, because people don't care about it, because it's a big job, we haven't got enough time. So absolutely, that is another cracker. And very specifically, that we are finding that at the moment with some of the work we're doing is understanding the impact of some of these digital changes, especially AI. It's massively important when we're thinking 5 years hence, but there's very little to go on, isn't there?
Another one, research delivery nurses are often funded in short-term roles, so it's difficult to plan for studies which may last 5 years plus when they're funded 1 year at a time. And that's about research delivery nurses, but there's a lot of roles in that position, aren't there? Short-term roles, short-term funding for roles.
I mean, we found all of this stuff around, apprentices, trying to get apprentices in, advanced practice, trying to get advanced practice in. There are no silver bullets in health and care workforce planning, but if there was, then one of them would be advanced clinical practice, or advanced practice as it is now. Sometimes very difficult to get those people in, to be able to get them contracts and to be able to run them alongside existing roles, the financial challenges that get in the way. So that whole thing about funding, short-term roles, etc., massive problem. Absolutely. Yeah. Absolutely.
And I guess the other side of that is over and under supplying the pipelines from HEIs, e.g. this year an oversupply of nurses, another year there'll be undersupply of nurses, won't there?
Yes, and we're seeing a lot of that at the moment. I don't know who's seeing, for example, a lot of physios without jobs following the long-term workforce plan push, for example. Physios are coming out and then not getting jobs in their local areas, of where a degree of, in that particular case, misalignment between what is expected or wanted or planned for in a strategy does not align with the amount of money that's available, and does not align with the changes that people were expecting in the workforce. That view of over and under supply at different times is a problem. Interesting that you mentioned an oversupply of nurses this year, because I'm certainly hearing people saying they think they're going to struggle to recruit nurses in future years. Somebody just mentioned there, I said 100 SNAs qualifying in October. We haven't got any vacancies for them, and absolutely makes it even harder for supply later on. So yeah, absolutely. I did note one there also about workforce planning done in silos. And yeah, absolutely, there's a bit of a solution in there about not making it so large that it's overwhelming. And I'm going to tick off on my list here, complex overlapping boundaries. Complex overlapping boundaries is a massive issue for us. So if we start thinking about things like, for example, in an organization overlapping with community, if you're in a hospital overlapping with community, now I'm just going to talk from a health perspective here, but you've got ICBs, you've got regions, you've got nationally, often those things conflict. Then you overlay the local authorities. So there are massive differences often with the way that things were happening there. So there are massive complex overlapping boundaries. Who's in charge? Who do you need to convince? Sometimes you can convince somebody to do something and then that person changes and then you end up with a problem. So yeah, absolutely, those complex boundaries. Somebody has come in there with data gaps and quality issues, and you are exactly right. Two I've got for data. One is data and the other one is data sharing. We find data sharing can be really problematic. People not doing the basics they need to do, not engage in data sharing teams. And when they do, those data sharing teams can be quite obstructive at times, and it's complex because data sharing is an art, not a science at times. And so therefore you don't know what rules apply where. And then when you have got ability to share the data, sometimes that data is A, poor, B, missing.
And there's another one there, Colin, about aligning training with the future clinical needs.
Absolutely. How do we get our workforce to fit the needs of a very complex future? And that's another part of workforce planning. It is a challenge. It's a key part of our job. It's not a barrier or a thing that should get in the way. This is an absolute key thing we need to be doing, the same as workforce supply, etc., as you say. How do we make sure that we can get our staff trained for a future that we don't know exactly what it looks like at the moment? And somebody mentioning there their system doesn't work together very well. I could probably guarantee that almost all of you are in the same situation. Systems often don't know exactly what their role is around everything. It changes quite a lot. The individual people within the system are not all controlled by the same group. Nobody is prime contractor. And so therefore it's very difficult to get a system to work together. And that has a massive effect on looking at the wider workforce across the teams. And quite often part of our challenge will be to try and move people between teams, get teams to work together, etc. And yet we don't have the same terms and conditions, don't use the same IT, etc., etc., etc. You'll see why we did note in our article that workforce planning is impossible, which we wrote many years ago. It has not got any more possible in the time, but it is worth doing. Let me just assure you at this point. There are a few others around the outside that we sometimes get. So sometimes people are a bit confused as to what it is. So people are asked to do workforce planning, but are they being asked to develop a workforce plan, do a workforce model, make sure we've got the right workforce in the right place at the right time, as in the whole thing? Are they thinking about hubs or whatever else? So there's quite a few issues around that. And linked to that, quite often not enough people to actually do workforce planning. We talked about not enough time, not enough staff. That could be people on the ground to do it, but not enough time for us to do it. And we might not have the skills. If you've been on the skills builder in the Association of Health and Care Workforce Planning, you will note that there are quite possibly 100 different skill areas that you could probably pick out for workforce planning if you want to do the whole thing. And of course, none of us have got all the skills we need in all the different areas. And then finally, just to link into some of your other points, which you have already made, is that for me, workforce change is system change. So what I mean by that is if we are going to do workforce planning, which I repeat, is to get the right people with the right skills, behaviours and attitudes in the right place at the right time to provide excellent health and care to the people of the United Kingdom, for example, in this particular case, let's say, then we need to take account of digital, as you already are. We need to take account of new buildings, new organisational structures, etc. It's not just about workforce numbers. And yet we need to quite often drive some of these changes. So, there's not a digital drive already in lots of areas. And so we're the ones driving system change. And we've got to solve all those problems while we're doing workforce planning. Cool. Okay, at this point, I'm going to introduce the guards. So they're the barriers to workforce planning for the association, and a bit of an explanation as to how you can use those, and we will get those out to people. And of course, if you come up with any other ideas, then please let Joanne know via support at AHCWP, and we can design some more cards. But let's start with a couple of the classics. So let's start with no money. So we've got no money for workforce. We've got no money to pay people to help with transformation. We've got no money to implement workforce changes. We've got no money for new technology. And funding for teams and people is not long term. So you mentioned a lot of those in our discussion. So how do we deal with the fact there is no money? Has anyone got any ideas what we might be able to do about that? Any thoughts? No? Okay. Well, I'm going to move to the back of the card then because there's different ideas. So I would argue that there is money most of the time. It's just not in the right place. So, for example, there is money in general in the health service. You might have a system that is spending £1 billion at the moment on health and social care, but it's all being spent already on other budgets. So this is one of the toughest ones to do anything about. But if you can go to senior levels to make the case to say, look, we can deal with workforce planning, it will actually be more efficient later on, then it's all we can do in a lot of cases is to flag through the chain to systems, to execs, or to whoever else, speaking their language to say, look, guys, if we want to get workforce planning done, then we need to make sure that we make the right decision. So, for example, if we need money for trainees, for advanced practice or whatever else, we need to make the case for it. For example, there's a lady called Jax Malander, but she does a lot of work around identifying the cost benefit of health and care changes, including advanced practice. And she also talks about it in a very intelligent and business focused way. And she's able to make the case to senior people that we need to invest the money from other places into this area. Now, at the moment, I've never known a more febrile situation regarding money in the health service. And it is also very bad in the councils that I'm talking to. So I'm not understating the risks and the issues around money at the moment. But if it isn't there, we have to make the case for it. Key part of that as well is freeing up the money where possible. So obviously, if we can reduce agency spend and recycle the money, that's a way forward. So there's a classic there of make a small change, bank the savings and try and deliver it. Key one there as well about seeking money from grants and central organisations. Less useful at the moment, I won't lie, because there are fewer of them around. So Health Education England and the like, NHS England, used to be able to provide money centrally. Some people still do have it. It's just it's higher up the chain or lower down the chain, in which way you look at it, towards the execs than it was before. But they are still spending money on things to make things happen. So you need to find out where the money is and target that money where possible. It is a barrier, and by doing this work, it does get in the way. It's very, very hard to do it. It makes workforce planning harder. So that's pretty much the main issues there. If anyone's got any other solutions, let us know about it and we can add that to the list. So no money is one, and then the other one is a lack of alignment with finance.
Before you go on, there's a comment in the chat about SIPs. We have significant SIP to achieve, including in workforce. So unable to recycle reduction in NHSP into permanent staff. Budgets have also been set below initial establishment last year.
Yes.
So they're now overspent. Yes. How have people had success with articulating, recruiting, taking time to educate, so then we can create a higher tariff income in a couple of years in a specialist service? Yeah.
Yeah, so that's the good point there about making the case for that change.
Yeah.
But it is really difficult at the moment. But workforce cuts, there are situations at the moment where people are saying we need to cut staff. So just say which people want to leave and those people can leave. well, great, but they were doing some work up until that point. So at some point, you're going to need them to keep doing that work. What you need to do is to go about reducing the demand for that work and then removing the staff. And in those cases, if you can make the case for change, that is a specific skill which we have in the association, which we call business cases. It's about, and it's part of the wrapped approach, is to develop that case at the end. Again, it's something that Clear does well for its work. For example, it should be a core part of your redesign approach, is to come up with a view that says, this is the impact it will have, make the case. The lack of alignment with finance is a key one, as I say, because the finance numbers trump the ones that teams develop. So we do see this quite a lot. We do see people coming up with workforce plans that say, right, yeah, this is what we need, and it gets cut. And so you end up with fewer staff than you need, and fewer staff than you want, and fewer staff than you discussed with people on the ground that they needed. So suddenly you're in a world where you don't have enough staff, inverted commas, which means because the staff believe they wanted and needed more and you're not providing it. But it's not a great situation to be in. And this is a very common problem. I don't know if anyone can think of any solutions to that lack of alignment with finance. So lack of alignment with finance. One of the key things with finance is, first of all, we need to understand where finance people are coming from. In general, they are there because they have a job to do, and their job is to largely to keep budgets under control. Not necessarily to keep costs as low as possible. Their job is often to make sure that we don't go over budget, because that's often what worries them more than anything else. But yes, often another one of their jobs is to get enough SIPs. And if we understand where they're coming from, then we can have a conversation with them about how we might be able to help them with their problem and how they can help us with our problem. What I normally do here is draw on the board a triangle, which many of you would have seen before, which has got 3 points. Obviously, it's a triangle. And those 3 points are staff, money, and patients or service users. And the point there is that there is always a challenge between the needs and desires of staff who want good pay, good conditions, they want fulfillment, they want enough time to do a good job, they want a great career and benefits. You've got money, which is generally we want to spend as little as possible within the organization, and you've got service users who want easily accessible, good quality care near to where they live generally. And there's always going to be pressure between those 3 groups. There's always going to be demand. If you give staff everything, the year later, they will want more. If you give SIPs to finance, next year, they're going to want more. If you give good services to patients, next year, they're going to want more. There's always this challenge. But the single thing that joins all of those up and makes them all possible to some extent or another is a big triangle called efficiency. The more efficient we are, the more we can give to staff, the more we can give to patients, the less money we can spend to do that. So there is always this balance between the 3. So we need to understand where finance people are coming from. We need to talk their language a little bit in terms of business cases, etc. But actually, one thing that we find you really need is a single joined up mechanism for determining the workforce figures. This is needed nationally because, to be honest, the long-term workforce plan wasn't costed. The system-wide, so we definitely want that within individual systems or regions, depending on how things fall out in that area. But we definitely need them within each organization. In the old days, we had an approach called service line management. It was popular for a while and then disappeared in hospitals. Well worth thinking about and looking up online. Again, we'll try and remember to put a link on for that. But you've also got integrated planning, which is a more useful thing that's happening now. People are developing systems for this. So Arden and Gem have developed a computer system that can really enable workforce, financial, and activity planning in one place. Because if you have that conversation in one place, right at the start, bringing in the fact that there is a financial issue, bringing in the fact that there is a need for patient care and safer staffing levels, etc., bringing in the desires and the ideas of staff in one place and engaging everybody in that conversation, then we have a chance of actually coming up with an agreed set of workforce figures that balance the needs of the 3 stakeholders. Appreciate I'm a sweet summer child. That is a very difficult thing to make happen. It's certainly never going to be perfect, but the more we can work towards that integrated planning, whenever we're doing workforce planning, do it with everybody, then I think we've got a more chance of making the case for efficiency, making the case for more staff in the right places, making the case for the right staff, and not only help ourselves, but help finance and deliver better patient care as well. As part of that, I say you should build workforce models to prove to finance what is needed. So rather than just saying to finance, we need more staff, which gets their backup, we are saying, look, activity is going up, or the demand for our services is going up in other ways, for example, when it comes to greater comorbidities or whatever. Build that understanding into a workforce model that says this is what's coming in, this is what we need to do to make it work, and this is therefore how much it's going to cost to deliver it. If you don't want that, what don't you want us to do? Do you want us to lower quality? Do you want us to reduce the amount of people we deliver work for, which might, taking somebody else's point, start hitting our tariffs? Having those conversations about individual areas rather than just we need more staff is definitely a great idea when it comes to workforce planning, and is a huge amount of my job is for pushing to make sure that everyone understands this in detail. And finally, a solution that Manchester found was to show the various workforce future pictures together. So if they show what finance are giving you, they show the operational one, they show some future ones as well. They showed some thought leadership about different areas. If you just keep showing those differences, showing the variation between those lines on a graph to say, you're giving us this, we think we need that, the impact is this, but just showing those lines all the time, bringing it home, not playing the game of what you're given is what you need, then that can also be very helpful as well, because we know we've got these areas, and until those lines are together, we won't have proper workforce planning. Any questions about that before we move on to time and scale and stuff like that? I can't see the comments, but there we go. Someone's got their hand up.
Hi, Colin. One of the questions that I get asked quite a lot, especially around the alignment to finance, is fluctuation in demand throughout the year. So we normally kind of do operational planning for one point of time for our overall financial budget. How do we now kind of assess that throughout the year? Because is there a chance that we might be underspending where needed or overspending at certain times of the year?
Yeah, that's the great thing about barriers, is once you've overcome one, there's another one coming up. It's like a hurdling race doing workforce planning. So yeah, how do you come up with that one? Well, there's some very interesting ones. I mean, you're looking at it across the year. You could also look at this across the day, across the week, etc. as well, because fluctuations in demand require more staff, generally, depending on how you set things. But you have to set a level as to how much risk you are willing to take. So there are certain scenarios at certain points of the day or week or year where you will not have enough staff. And there are certain points when you're going to have too many. You can set your line if you are, so I used to work in retail. If you're Harrods, you set the number of tills you had open to the absolute time when you set it right to the top of those peaks. You made sure you had loads of extra staff available because you were selling some really good stuff, right? And we wanted to make sure we were getting stuff through. So working for Harrods was very interesting because they were really real premium retailer. Marks and Spencer also did the same to a slightly lesser extent. And then at the other end of the scale, when we were working with people like, for example, Ethel Austin, which no longer exists, for example, a cheaper retailer, for example, you might say your Aldi's or whatever else. I've never worked for them. Well, what they're doing is they're setting their staffing levels a bit lower because people don't expect to be able to see people quicker, for example. So they're setting it lower. So they're managing their demand a little bit, and they're setting their staffing levels at a lower level because they don't mind if people do walk out the door. It's better than having a large overhead of staff, for example. So there's a few areas of this. One is it's about setting your customers' expectations and flattening that demand to get them to come in or to wait. But there's also about where you set your staffing levels too. And when you're modeling, you can actually set a percentage to say, yes, if we're setting it higher, then you're going to need more staff. And that's true, as I say, during the day, during the week, and across the year. But yeah, absolutely great question. When you're building a model, you can't just assume that everyone's going to come in a nice line. Or you can do, but they don't always do that in certain circumstances. Some of our stuff, we can manage demand. Other times we can't. I remember working in a retailer once that had a bus stop outside the shop, and managing demand there was really hard because when the buses came in, they had a massive spike and then they had no work for about 45 minutes, and then suddenly a massive spike and then no work, massive spike. So setting your staffing absolutely critical based on peaks and demands.
Question about AI. Well, it's a good one, actually. Do we think there'll be an AI solution for workforce planning soon? A way of looking at demand against staffing required?
There are forward-thinking people on this call that are want that in systems that they are looking to try and procure. So absolutely, yeah. So AI has two impacts for us. I think one is an impact on the staff we need. So what's the impact on our administration staff? To what's the impact going to be needed on our social workers? What's the impact going to be on our doctors, nurses, etc. On all of our staff? Is going to be massive, right? So that's one problem which we need to work out what that is. And one of the things we want to do through the association is try and bring together groups to think about that a bit, because obviously it's massively important, but there are lots of intelligent people doing some thought leadership on that we need to bring together. We are going to do a session on that separately. But your question is about AI and workforce planning, and absolutely we can do a bit of a session around what that might look like, by the way, because we did some thinking about that for this forward-thinking client. But artificial intelligence absolutely can do a huge amount of stuff. Some people are already introducing it, but it depends what you mean by artificial intelligence. Are we talking about having an automatic version of some of the people in this room, some of the experts in this room, to say, this is your answer to any question, chat bots, etc. I don't know how far away that is. Are we thinking about pattern recognition and being able to identify how many people you need? Then actually some of those systems already exist to some extent or another. So little bits of AI were creeping into the Arden and GEM system, for example. So I think it depends on what we mean by AI, because it's a broad area. I don't know where some of the more forward-thinking stuff is. I do know that some of the early stuff is already here, and I think there'll be a spectrum of that. But I would be very surprised if people are not marketing systems in this area in the next couple of years.
Colin, we did have a discussion, didn't we, about innovation, and we covered some of that, what people were thinking. So I will link that podcast into the notes for this meeting.
Good point. But yeah, it's going to make a massive difference, isn't it, really, AI? So we've got to keep an eye on this as a group of people. And if anyone's got any good thinking stuff on AI, if we can bring it in to the group and start spreading it around to everybody, that'll be really good, I think, because it's going to be fundamental at some point. We normally say, though, 6 months ago, I saw a fax machine in a trust. So the chances of AI taking root can take a bit of time. But yeah, absolutely worth looking at. Going to rattle through a couple of others, just introduce you to the cards more than anything else. So the idea of the cards is that you've got, on the front, you've got the problem. So if people raise them in a group, you can raise them, if you're training people in this stuff, people raise them in a group, you can show them the front of the card. So for example, not enough time, too much work to do. People can't free up time to get involved in change. That's why I was told to get knotted in a GP surgery, for example. Leaders don't have time to focus on it. And then on the back of the card, you've got the answers to how you might be able to solve these, a few ideas. Maybe we can add a few examples as well. So if anyone's got ideas for any of these, let us know. We'll add them to the cards. From a not enough time point of view, I would always argue you've got enough time. All right. You guys are busy people, but you're on this call. Yeah. Some of you may be regretting that, but you're on this conversation. Yeah. Why? Some of you are doing other work in the background, obviously, but also some of you are thinking, this is important enough for me to do this bit. So you've prioritized it. So sometimes you just need to prioritize workforce planning for the good of the future, for your good, for everybody else's. That's one. Secondly, we do need to understand the demand for what we are doing. We do a lot of work, and there's often a question of, let's have a look at what we're being asked to do and what can we stop doing. We worked with a team of people that developed, in private sector, a team of people that developed reports, and they were always saying they didn't have enough time to do any work around it. So what we said was, right, okay, let's just not produce any reports this week. And then after we dealt with the 5 or 6 people that were really upset about their reports not being done and did those reports, we found that we had 3 days spare where people were not worried about the fact that a report hadn't been done. So we can think about, can we stop doing some things? Obviously, if that's healthcare, not quite so easy, obviously, but there's often things we can think about as can we stop doing? And then, as I say, a bit like with money, if we can change one thing, save time, and then use that for the next change, that's great. Great thing about general practice is they often have Wednesday afternoons off, inverted commas, certainly off from doing operational stuff, which means they get time to do stuff like workforce planning, to do stuff like training, development, etc., or looking at processes, etc. So if you can start to save time, bank that, and try and keep a spare afternoon a week, obviously not for everybody, then of course that can be a great thing. Set your expectations for the delivery. Actually plan the time. Make sure you are going to do the work. And when you are doing it, make sure you implement it rather than just spending the time, taking up people's time to do workforce planning and then not implementing it. We are running out of time, so I'm going to just quickly rattle through a couple of others. The sheer scale is a problem, and we've talked there about AI, robotic process automation, which is much more likely to come in quicker, by the way. Robotic process automation is, you actually find it in Excel, for example. You can record yourself doing something, and then you can then just get it to do that whenever. You can basically train systems to be able to do quick work, screen grabs, etc. It's quite nice, well worth looking into. But there's a huge amount of stuff going on. Digital, new pathways, new care models, 40 new hospitals, massive amount of stuff going on. As Desmond Tutu said, it asked, how do you eat an elephant? And the answer being is you do it a bit at a time. And that is often what we do, is to think about what is it that we can do. So just write stuff down so that we're starting to record everything we know, because it's a complicated world with a load of stuff going on. So we often create packs of information which record everything we know about a topic and what we've decided to do, and make them quality documents where possible so that we can share them with other people. And it helps to break down the problem into manageable chunks. One thing there as well about prioritize redesign over delivery. Some of the other people that I've been trained with in the past have talked about mopping the floor while the taps are running. There is a lot to be said for taking time from delivery where at all possible. Obviously, you can't always stop the taps all the time, but being able to take the time to redesign, especially the most common problems. If anyone's ever done lean, then yeah, they really take that to the nth degree by stopping the production line whenever there's a problem and solving it there and then. Solving small problems can be really helpful. Bold changes needed. I think as Em mentioned as well, the fact is that we do need to bring people along with change. Things are going to change for people, and that isn't always popular. If your medical secretary is going to become a robot, if your buildings are somewhere different, if your day is changing to a 3-session day, etc., 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 these have fundamental impacts on people. There are going to be organizational winners and losers, and there's going to be individual winners and losers. It is a quite difficult world that you're working in. System-wide organizational design is needed and not happening, but where they are happening, need serious support. So the key thing that often we are doing is saying you need to raise the issue of working across system to solve these problems at every governance meeting you get a chance to do so. And those of you that work with me will note that that's something I do all the time. If you can, taking the previous point as well, make one change and show what can be done, then that can often have a massive impact by proving what impacts are and giving people the comfort that it's not going to be too big a deal. One of the new hospitals I'm working with, they are looking at introducing things. They've got a concept ward that allows them to introduce nursing changes early, so you can see these things. They want to introduce the digital and estate stuff early on so people can see that impact. So it's not just about workforce, it's about everything. So quite often what you need to do is engage your transformation teams and get them to talk about workforce as part of it, rather than you having to do everything yourself. So part of the aim of the association is to train not just workforce leads, but to train system leads and other planners in workforce, because workforce is a part of system transformation. It's a part of the digital organizational process and estates change that we need across health and social care. You can also use an approach like CLEAR that does both. CLEAR, lean, theory of constraints, etc., does both, and we certainly relate to that when we use RAPT as well. lack of people is a problem. Actually developing a workforce plan for workforce planning staff is a great idea. Developing transformation plans that get the transformation done quickly is definitely the way forward. We often develop a lot of work for ourselves as transformation leads, as workforce leads. Try and think about how we can do these things incredibly quickly. For example, rapid improvement events as part of Lean can be done within a couple of days, bringing everybody in to solve the problem and then moving on, getting them to come up with the plans and then ruthlessly delivering on that work and checking that work can actually be a better way of doing it than running a 16-week project, which steadily disappears into the long grass. So there are things that can be done around that. From a lack of skills point of view, again, somebody on this call wrote a paper that said, I think it was something like 40 to 60% of people's time should be focused on developing skills, redesign, etc., and working on their own well-being rather than on work on the ground. And I think that is absolutely right. It's tough to get 5 minutes to yourself these days, but I would certainly say that you need 20% at least of your time spent on training, process redesign, etc. Some roles will need up to that 60%. So breaking out that time, difficult though it is massively important. And obviously the Association of Health and Care Workforce Planning has got loads of skills stuff in it. There are many, many other barriers and there are many, many other solutions, but I'm going to end it there because you're going to get those slides anyway at the end and we're coming up to times.